Hey, good afternoon, everybody, or good morning, depending upon where in the country you are. And if you're watching this on a rebroadcast, then maybe it's good evening or very early good morning. My name is Eric Rubenstein, and I am the Senior Director of Litigation, Fraud, Waste, and Abuse Support here at Advize Health. We want to thank everybody for tuning in to the first of what are going to be many webinars that we're going to be doing in the future here at Advize, both internally and with some of our partnerships. And I'd like to welcome you today to this presentation, which is called Taking a Payer Organization's Anti-Fraud Vital Signs. Really, what this presentation is going to be about is really more about a blueprint for SIUs. It's going to be what are those best practices and what are those concepts that are going to come out as a result of that. Our presenters today are Bill Mahon and Matt Kochanski. I'm going to let the two of them introduce themselves in a second, but these are two individuals who are really what we would consider to be best in class in the area of SIU operations and in the management of SIUs and in process improvement. Now, we know there are a lot of you that are out there that are working in the SIU space, and we hope that at the end of this presentation, you'll have a few things you can take back to your organization. Working very hard with a lot of our payer clients on some of the things that you're going to see as some of the concepts here, because it's all about, from the payer side, it's really all about that return on investment. And we're working very hard with our SIU clients to ensure that when you do have a situation where there can be some process improvements, whether it be making a referral to law enforcement or the like, or to your payment integrity groups, that these things are being met. I'm a retired special agent from HHS OIG, and I work with a large team that we have here of also retired special agents from the OIG, which makes Advize a bit of a differentiator because we understand both healthcare fraud, we also speak the legal parts of it, and we speak the medical record review piece of it. I'm going to turn this over now to Bill and Matt, who are going to introduce themselves, and we're going to do a little slide presentation and hopefully get some good information out of this. Bill, let me turn this over to you first.
Thank you very much, Eric, and good morning, afternoon, evening to all of you as well. We really appreciate you making time to join us today, and we're looking forward to giving you what I hope will be some good food for thought and some good takeaway value from the session. I'm an independent consultant in the healthcare fraud field. I've been in it for a little over 31 years now and ran the NHCAA as their chief staff executive for many years and began my own business in consulting in 2004. And a lot of my work has focused on working directly with private payer, special investigations, and enterprises to gauge the overall effectiveness, not just of the SIU, but the overall anti-fraud function as it permeates the organization. And that's part of what we're going to talk with you about today. But I appreciate Advize and their team inviting me to participate today, and we're looking forward to discussing with you.
Great. Thanks, Bill. My name's Matt Kochanski, as Eric referenced. I'm a retired HHS OIG agent and headquarters official. I spent 17 years with them as a special agent, and then in their headquarters operations where I ran multiple programs, including their national healthcare cases, and as well as their undercover activities, their consensual monitorings. I was the liaison to the NHCAA as well as the liaison to CMS when I was with HHS. I finished my federal career with 7 years with the NASA OIG, where I was the Deputy Assistant Inspector General for Investigations. And then upon retiring, I joined the contractor world, and I became the fraud manager and then the program director for the Unified Program Integrity Contract Northeast, working the Medicare and Medicaid program integrity mission for CMS. And I did that for the past 8 years. I joined Advize about 6 weeks ago, and as Bill said, we're both very happy to be making this presentation, and hopefully we'll provide you some information that'll be of benefit to everybody that's listening.
Thanks, Matt. And I think once you heard now that about Matt's background, you'll see, I hope, that we have the sort of two sides of the coin, the private, public sector sides covered in terms of our experience and backgrounds. And what we're doing today, we're sort of mixing our metaphors on you a little bit. We did talk about taking the organization's vital signs. And then, as Eric mentioned, we're titling the slide deck here a blueprint for anti-fraud effectiveness. You can call it anything you want, a blueprint, vital signs, a checklist, an inventory. But what we're going to be taking you through is a high-level look at what, in our opinion, constitute the essential ingredients of not just a special investigations unit function, but an overall enterprise anti-fraud function that is well-rounded and effective. It's a subjective view, admittedly, but it is based on experience of many years in working with both private and public sector clients and agencies. And it's not perfect. One thing we'd be interested in as we go through it is, do you see gaps in this that you can share with us as we go along or at the end of the presentation? It's an evolving document. We began many years ago now when we said, well, what would it look like if we put in one document, everything we think an anti-fraud function should feature in order to be complete and effective? So we did an Excel spreadsheet. The slides you're going to see today are extracted from that one document, but they all interrelate to each other, as we'll be showing you. So why don't we go right into it? It's going to be a high-level look, considering our time frame here, but again, we hope that it's going to be enlightening and useful, and will help you go home or go away with some things that that you might want to address within your own organizations. So if we can look at the first slide. Here we go to the blueprint. If we assume that the structure you're trying to build is the comprehensive approach to your fraud exposure and your anti-fraud activity, then the other 4 items here: detection, reporting, investigation and referral, case resolution, fraud prevention, those are the pillars that are going to support that structure. And the way in which you construct those pillars is going to have a bearing on how strong the overall structure is and how well it stands, how long it stands up, and so forth. So we're going to be taking you through each one of these sections that, again, bear in mind, come from one document, one column per section. But here we're going to take a discrete look at each one of those. So we'll start with the comprehensive approach. If we can go to that slide. And this shows us, again, the structure you're trying to build. The most important thing on the slide that I've always emphasized to people is the very top bullet here: the commitment and the visible support at the highest management levels. The most effective SIUs and anti-fraud functions that I've seen in my years in the industry are those in which everyone in the organization knows that the anti-fraud function is important to the CEO of the organization. And if it's important to that person, then I know in whatever department I work in, it has to be important to me as well. And I need to play my appropriate part in supporting that overall function. So you start with that. You need that awareness of the risk, the appreciation of the risk, and the understanding and support of the anti-fraud function, which is not optional, as you know. Many years ago,
A few moments later.
I'm glad you can hear me now. That's good. Well, why don't we back up one slide real quick, and we'll just give a nutshell. I began by saying we're going to mix our metaphors on you. Our title was Taking the Vital Signs of an Anti-Fraud Function, but here we're talking about it as a blueprint. You can call it a blueprint, a checklist, an inventory, but whatever you call it, we're going to be taking you through our view of all of the elements that go into not just an effective SIU operation, but an overall enterprise anti-fraud function, in this case, specializing in the healthcare arena. So each one of these circles that you see, if you assume that the comprehensive approach is the structure you're trying to put in place, then the other 4 bullets here, 4 circles, are the pillars that are going to support that structure. And how strong the structure is, how well it stands, how long it stands, is going to be dependent on the strength and the completeness of those other 4 pillars of the organization. So let's go right to the next slide and we'll get caught up here. The most important thing I've seen that contributes to an effective anti-fraud operation over the years is what some people call the tone at the top, but whatever you call that, the commitment, the support at the senior-most levels of the organization. Bottom line being that if everyone in the organization knows that the anti-fraud mission is understood, appreciated, and important to the CEO of the organization and other senior management, then whatever place I occupy in that organization, I know that it better be important to me too, and I need to play my part in contributing to its effectiveness. So you have to begin with that. Absent that, you wind up sometimes in a siloed, reactive mode, Sometimes you wind up feeling adversarial to other organizations, other parts of the organization, like claims or provider relations, network management. But if that senior management support is there, that forms the basis of a good, thorough, well-rounded approach. Assuming you have that, you have to have a formal policy for dealing with fraud if you're in this business. You can't react, you can't wing it, reacting to everything that comes up. You need to react to those things and address them in a framework that you've thought out in advance and in which you know what you're doing. The policy is one thing. You have to communicate it effectively to the organization itself, to your external audiences, your customers, your providers with whom you deal, your vendors. Everyone with whom you deal has to know this is our policy on fraud. The policy is one thing. Implementing the policy requires a formal plan. And that's not an option if you're in the private insurance business around the country, because you know that so many state insurance departments have that as a fundamental anti-fraud requirement, submitting your formal plan to the state insurance fraud authorities. What are the elements if you're going to put that plan together? One, you start with your objectives. You want to prevent losses. You want to recover losses from fraudulent claims that have been paid, and overall cost containment for everyone's benefit. It's not just the money, though. You have to bear in mind there's a very important patient and member protection component to your anti-fraud function. You've seen many schemes, I'm sure, that put patients at risk physically, in addition to exploiting their insurance benefits. So the physical well-being of your patients, the availability of your benefits, even in the wake of the ACA with no lifetime caps, there are still discrete benefits such as behavioral and others where you do have caps on benefits every year, for example. So to the extent any of those are lost to fraud along the way, that is reducing what's available to your insureds. The integrity of your insured's medical histories. If I'm going to send you a fraudulent claim, I have to make up something about what was wrong with you and what I did to take care of that. That becomes part of your claim history, your medical history, at least in the insurer's eyes. So again, it's much more than money that's at stake here. So in addition to preventing losses, containing costs, protecting your members is key. Full regulatory compliance. If you're in the government business, in Medicare Advantage, Medicaid, managed care, you know that you have a host of compliance requirements to which to adhere. And in the CMS world, in Medicaid, Medicare Advantage, you know that in Chapter 9, Part D, Chapter 23 in Medicare and Medicaid, you have to have a special investigations unit or its counterpart, typically housed within your compliance organization or operation. But again, there too, you find a host of requirements to ensure that you're doing the sort of anti-fraud work the government expects you to do. So once you have your objectives, how are you going to achieve them? That requires clear strategies for pursuing those objectives and meeting those objectives. And those will take us into the next slides that we'll see. Strategy for detecting fraud and reporting it internally to the investigative unit or the anti-fraud unit. Strategies for how you investigate, how you refer the results of your investigations. Strategies for resolving cases, criminal referral, civil action, direct recovery demand by the Special Investigations Unit. What kinds of criteria are you setting there? What kinds of strategies are you going to pursue in those 4 areas? Prevention, that's something that we'll spend a lot of time on later. And on the thesis, as you know, that it's much better to keep the fraudulent claim from being paid in the first place than to spend who knows how much time and money chasing a small fraction of it as a recovery. So once you've got your strategies, the next question becomes, well, what's it going to cost? How are we going to fund it? And let's make sure that we fund it adequately in order to achieve the objectives we're pursuing with those strategies. Training. The entire organization needs to be trained in fraud awareness. Again, another common requirement of the states. But then you have to go beyond that and make sure that the people in key positions are trained in relation to what they do and how that relates to the anti-fraud mission. And finally, oversight. It's not enough to set it up and put it on autopilot. You always want to be benchmarking and comparing measuring how you're doing against realistic expectations. You can't expect the moon. You have to be realistic and measure yourself that way. Measure yourself against other organizations as well. There are industry best practices. There are the NHCA anti-fraud management surveys that let you take those vital signs, to go back to the other metaphor, but also do a periodic review with an external set of eyes. Matt and I are in the process of doing that right now for an organization, and they see the importance of having an external, experienced, objective view that, as Eric Rubenstein said, speaks the language, speaks the SIU language, speaks anti-fraud, to go in and give that critical external look at what's being done, how it's being done, and what kind of results it's achieving. So with that, let me ask Matt. We'll go to the very first section here on detection and reporting, and let him take us through that.
Sure. Go to the next slide. Great, thank you. Yeah, detection and reporting. Detection, has to be done at the transaction level, at the claims level, where even in enrolling the providers and in credentialing them, you have to have due diligence in making sure that you're bringing into the program the providers and that you really want to have brought in. And you'll see that without that type of gatekeeping, it is very difficult. You're in a pay and chase immediately after that. This initial gate is probably the most important in terms of going to that last pillar, prevention. Having communication and coordination between who's enrolling the providers and the SIU unit to make sure that there's a dialogue going on. Who are some of the suspect providers? Who are their associates? Are there suspect addresses that should be red flagged? It's very, very important to do that right at the credentialing and the enrollment stage. Going into claims analysis. Once the claims come in, again, it's coordination, it's cooperation amongst all of the entities. With the SIU data analysis and the claims processors to work out, are there edits that need to be put into place? Are there suspect symptoms of claims that need to be ferreted out even before payment? And generally what I'm going to be talking about through this whole process is you've got these 4 pillars. What's needed to make them effective are cross beams, where you're taking those 4 pillars and through collaboration and dialogue amongst the representatives of who's working in those areas and making sure that they communicate and that they have the same priorities and the same strategies. You're able to build those cross beams so that the credentialing folks will know what to look for in an enrollment application to see whether or not questions need to be raised about that person before they go in. With claims, are there certain things, are there patterns that we're finding in the SIU that are suspect that we need to show up front, that maybe we can get upfront edits put onto those claims so they won't be paid? So all of those things come into play throughout the life cycle of a claim. Technology-based, claims system edits. Those have to be put into place to really save the money. The red flags on providers, on specific diagnosis and procedure patterns. Certain things just don't fit. We've seen many instances where you see a certain set of procedures and the diagnosis are always the same, and it's an earmark for a scheme. I can give some great examples of that in terms of transcranial Doppler exams being conducted by ophthalmologists as part of annual screening eye exams. They don't fit, and they were just added on as very lucrative screening procedures with no medical benefit. So working with in Medicare, working with the Medicare administrative contractors, we're able to work with them to put edits on those things to stop those procedures from being paid when certain conditions are met. Geographic areas, again, with looking at high risk areas within certain geographic areas. Are there specific zip codes that are that are more problematic than others? Are there specific addresses where you see series of providers using the same address? Or are you seeing multiple DME companies being opened up on a specific street? And those things all come through, enrollment, credentialing, through the claims process, through the edits that are in place, all the way through the SIU, and there should be dialogue up and down that chain so that we can stop these things either before they start or as early as possible. Data mining and analysis. Within the SIU, you have to have a strong data and analytical component. And that analysis has to be not done in a vacuum. It should be done in the context of what are the priorities of the client, of the payer. What are some of the most vulnerable areas in terms of, what are the biggest paying specialties right now? What are the biggest paying procedure codes? What are we seeing in the SIU as things that are popping up as trends, so that the data analysis can be done within the context of being the most effective possible. So they're not just, casting the net wide and hoping to catch something. They're actually targeting their analysis to something that's known to be of a suspect nature. Detection technology, analytical skills, if possible, get the tools that you need, whether it be SAS or other tools that are available. Pick what's best for your organization based on the resources you have and the skill sets of the people that you have on board. Be very cautious and careful, but look for those things because they are of incredible effectiveness when used well. And analytic skills, those are very important to be able to go behind the numbers, look for those patterns. What do those things mean? And then you have to apply that analysis to, well, what are the rules that are in place? What are the policies? Why does this make sense? And then you also bring in the clinical insights from if you have an MR staff. There's this pattern of claims and procedure codes with these diagnoses. Do these make sense to you, or is that a problem? And then you can build projects and build proactive analysis based on what the rule is, how is it being broken, and what is the best way to approach it, clinically and investigative wise. And then the investigators, they need to work with the data analysts and the MR folks to come up with a comprehensive investigative plan and strategy on how to address individual cases as well as projects. Bill has here intelligence. Working with law enforcement and other programs and other payers is hugely important. You learn more from them than you will from looking at data. You'll learn what they've been seeing out in the field, what's important to law enforcement, what are some of the elements of evidence that they need to see before they'd be interested in a case, or what is prime in their jurisdiction, what are the types of cases that prosecutors are interested in that they will want to bring to fruition, so that you'll know where to put your resources. Without that, when you refer something to law enforcement, eventually you don't want it to be a surprise that they don't want to see. You want it to be something that they're expecting, and something that's going to be of the quality and have the information in it that they need to be able to then take those cases to the next level, which is taking it to the prosecutors to get them accepted and to work formally until it's resolved. Working with other plans and programs. As in the UPIC, we worked very hard to collaborate together. If someone found something in terms of a scheme in their jurisdiction, we would share it with the other jurisdictions. Yeah, we're competitors, but we also have the same mission. And we worked national cases together based on things that each individual UPIC found. And that type of collaboration was very important to the effectiveness of our anti-fraud efforts. Healthcare agencies and entities, again, working with all of the payers, with the NHCAA, with all of those other entities to gather information from them. they're a great source of both trends and individual suspect providers that are causing other problems to other folks. Get that through the media. This is something that you can gather intelligence about as well as use as a deterrence. You don't know what the effect of a press release is about someone being indicted or going to jail, but it is a tool that needs to be used both to read those to see what's going on as well as to create them to create that deterrent effect. Case information sharing, again, sharing that information, so you don't conflict. You don't want 2 or 3 different plans or a law enforcement agency and an SIU unit to be working on the same case unbeknownst to each other. You want to be able to collaborate and coordinate those things so that the provider isn't burdened with 15 different medical record requests from 15 different agencies, or worst comes to worst, you compromise the work that a law enforcement agency is doing by going in and alerting a provider that he or she is being looked at. You want to make sure that collaboration, that deconfliction, is happening from day one that an investigation is open. You have to have those processes in place to do that. And then audit-based, these audits are very needed. Something might not rise to the level of fraud, but there are regulatory and policy or clinical regulations, clinical standards that are not being met. Auditors and the audits that they conduct are absolutely necessary to be part of your overall anti-fraud effort. And frankly, in doing an audit, you might come across that it went beyond just a lack of process or a lack of regulatory compliance, that they are taking advantage and it goes to the level of fraud. Eligibility audits as well, looking at the members, making sure they're eligible is a huge part of the anti-fraud effort. And then external complaints, yes, everybody should have a hotline. Everybody should have member awareness. They should go out and speak with the members. They should the explanation of benefits should be out there. There should be communication as part of investigations and routinely with members to make sure that they're getting the services that they're receiving, that they receive them from the person that billed for them. That should be a standard investigative step, is to interview the beneficiaries and the members. And then also, do outreach to communities to make sure that they're receiving what they need. Going back to Bill's initial thing of, making sure the welfare of the benefit of the members is of the highest priority.
And Matt, picking up on a couple of things that you've touched on here, this is a very good illustration of that collaboration and the need to work together. When we look at things like claim system edits and red flags, what have you, there are a lot of technology-based claim system edits that are out there, everything from CCI edits to other types of rules-based things. But we have to make a distinction between that kind of technology at the transaction level and the separate and distinct data mining and data analysis that you talked about within the Special Investigations Unit. That's what feeds the claim side with red flags on providers, on zip codes, on diagnoses, procedures. So you've got claim systems alone, or claim edit systems, do not make for the kind of comprehensive anti-fraud protection that you need. There has to be that two-way communication and two-way collaboration there to cover those bases. When you talk about geographic areas, the SIUs would be in a position to say, if we're in California, we need to flag urine toxicology claims coming from labs in Florida. You don't just automatically pay those. We're aware of a nationwide phenomenon in that area. The other key point when we talk about audits, that's another area that feeds the SIU and that the SIU can feed. I've always said audits identify discrepancies or findings. They identify the what of something. Only the investigation determines the why if fraud is involved. So in cases where the auditors suspect that their findings might reflect fraud, they're feeding that to the SIU. In cases that the SIU opens up that turn out to, in its judgment, not to be fraud, but problematic nonetheless, they in turn can feed that to the audit side of the house for being addressed appropriately. Ready for the next slide? So we've got detection and the reporting within the organization of things that are detected at the transaction level through audits, et cetera. But then we get to investigating the cases and referring the cases. One, the Special Investigations Unit, and here we're presupposing an internal SIU, but there are instances where plans might contract with an external organization, not just for technology, but for investigative services as well. But when you have an SIU, it has to have an appropriate place, an appropriate upward report in the organizational structure. And for many years in the NHC surveys, you would see legal or internal audit as the principal residences of the SIU within payer organizations. In recent years, we've seen a trend toward housing them in compliance. I think that's a direct reflection of the extent to which the industry has moved into Medicare Advantage and Medicaid managed care, for example, where there is a sort of joining at the hip of SIU and compliance in the regulatory oversight world. Places that shouldn't be. Years ago, we knew of a plan, it's probably a major plan, whose SIU reported to the marketing department, which never made a lot of sense to me. But other places you wouldn't think to put an SIU, provider relations, network management, claims. In New York State, when they first imposed their requirements, insurers, they specifically said the SIU may not report to claims. There has to be a wall between claims and the SIU, even at the upward report level, because of a perceived conflict of operational interests. You know, the claims department might have looked at the SIU and said, well, we know they're here. They're not here to speed things up. That's one thing we are positive of. They can only slow things down if we see claims coming or if we see the SIU coming. So you want to have that sort of arm's length relationship operationally.
Right. With the government bill, with the CMS, you know, the SIU, the UPICs, they are completely separate. You know, they are a separate entity from the MACs that do the claims processing and the enrollment. And CMS did that purposely to avoid that conflict.
Mm-hmm. Yeah, going back many years, you know, the claims side would look, or management would look and say, well, yeah, the more aggressive we are in fraud, the more we report there, the worse our claims operation looks. So right. Again, very important to keep those at arm's length. Managing, staffing the SIU, these are the qualities you would look for. Somebody has to have good management skills and abilities, experience, investigative skills. Matt talked about people with those analytic skills. There has to be an inherent curiosity that makes part of a good investigator. Objectivity is another key ingredient of an investigator, a key quality. You can't go into a case assuming that you're finding fraud or assuming fraud at the beginning. One of the investigators I worked with a long time ago said, you know, the best thing an investigator can do is try to disprove fraud at every turn of the investigation. So all you're left with is a conclusion of fraud. If you can't disprove it 8 ways from Sunday, you're left with a pretty solid conclusion. The tool.
Yeah, just on that, Bill, you know, I cannot agree more that a curious mind is the key component of an investigative skill set. The ability to ask and formulate those questions that take you deep into the investigation and not be satisfied with the surface answers or the data that you really want to dig and you want to solve this puzzle. That more than knowledge of the programs, you can learn that, but bringing that inquisitiveness, that open-mindedness into the job is what's absolutely essential to the success of an investigator.
Yeah. True. And where can you draw on those things? Operational knowledge. A lot of SIUs will have very experienced, outstanding former claims processors and claims supervisors, adjudicators, now migrated into the SIU because they know the claims operation inside out, and they know what's important to maintaining that operation and not disrupting it, but making sure that the anti-fraud bases are covered. The clinical knowledge, how is your SIU supported in terms of medical review, clinical review? Do you have dedicated medical support or medical director support? Are some of your investigators RNs, for example? A lot of people tell you, and I wouldn't disagree, that nurses can make the best investigators because they have the clinical knowledge, they have the investigative instincts and skills, and typically they're not shy about asking the tough questions if they have to speak to a provider. And they know enough to judge the answer. Go ahead, Matt.
I was going to say, in the UPIC, we would make it a habit of bringing nurses on interviews with us, both with beneficiaries and with providers, just for that purpose. For beneficiaries, let's say it's a home health case, they're judging whether that beneficiary really is in need of home health. With providers, it's to make sure that we're not being white coated to death. That the clinical answers that provider is giving make sense. It's the nurses that can do that. I can give an example. If we went on site to a provider's office where the nurses came and they found, what's investigators probably would have overlooked, which they found, going into the refrigerator and finding outdated pharmaceuticals that weren't approved by FDA. They were actually imported from a foreign country without any type of approval. So that case then took on a completely different path based on bringing those nurses on board onto the onsite. It's invaluable to have that clinical insight.
It is, and we talk about IT, data knowledge, and skills as part of the SIU. It doesn't mean that you have to have an IT guru within your SIU, but you have to have some degree of knowledge and analytic skills that Matt talked about. But what we're saying here, I think, is you need to appreciate the value of data. You need to be able to access it and navigate it, explore it, and assess the results that you're getting from it. It used to be the case, and is still the case, sadly, in some places, where if an investigator in an SIU wants to see all the claim data for a given provider or for a given procedure, what have you, that investigator has to write a ticket to IT and wait who knows how long for that data pull to come back to him or her. But the generations of desktop tools that you see today house the data, 2 or 3 years worth, in software as a service products. They enable the investigator or the analyst in the SIU to access that data. They present it with predetermined results of predetermined queries and models within those tools, but they also enable unlimited navigation and exploration of one's own data to allow for those ad hoc queries. But that's the kind of user friendliness type of access and ability to use data and explore it that you want within the SIU. Appropriate jurisdiction and operating authority. The SIU can't make us up its own rules. Someone has to grant it that authority, typically legal and senior management. But the question there is, does the SIU also oversee internal fraud by company employees or by brokers, agents, what have you? Or is it somehow focused solely on external issues and populations? But that's something that needs to be well defined. Formal operating principles and procedures. It's not, investigating fraud can't be a paint by numbers process, but because you're always reacting to the uniqueness of a given matter. But when we say operating principles, procedures, those would govern the integrity of investigations, the objectivity of investigations, the reporting formats and content of investigation results and so forth, so that there's a consistency and a roadmap that you can point to in deposition, for example, or in trial testimony, so that you can demonstrate that, no, we don't wing it when we investigate suspected fraud. We follow formal principles and procedures that keep it professional, keep it objective, and keep the results reliable. The relationships with law enforcement, other plans and programs Matt talked about, that's a key ingredient in the investigation side, because typically if Dr. Jones is doing a bad thing to one payer, it's highly likely that he or she is doing it to several other payers as well. Why limit it to when you have the opportunity to do it to more than one? so that information exchange and the collaborative approach is key there. Matt talked about the cross beams of the structure, which I loved. When you look at these internal working relationships, we won't go through every single one, but think of all the things that go into your health insurance operation and your constituencies, and you begin to see a pretty long list of organizations with which the SIU has to have a working relationship, and not just on paper, but an effective one. Take areas like network management, for example, or provider relations. Those are key because that's another area where there's a possibility of conflicting operational interests and business objectives and so forth, especially in the network. But there has to be an understanding in those other areas of what the SIU does and why, where they come into the picture in terms of supporting that anti-fraud function. And finally, we mentioned earlier, entry-level and ongoing training, which is another very common and widespread requirement of the state insurance fraud authorities. You can't just, again, train someone upon hire and assume that 3 or 4 years later they're going to be retaining all of that and doing everything they learned. That has to be an ongoing training because the fraud itself evolves and technology evolves and regulations evolve. So you need to keep up with that effectively. Why don't we look at the next slide? Resolving cases. I'm going to let Matt talk about these two, but this harkens back to what I said at the outset, that you have to have a roadmap. You have to have a plan for how you deal with the types of cases that you're identifying and investigating and getting set to take action on in the SIU. Matt, why don't you take over on this one?
Sure. Yeah. Criminal prosecution. That is the ultimate, goal for any SIU investigator, is to find that case that is going to end up in a criminal court. And what's the criteria for that? That's going to depend on each law enforcement agency to whom you're going to make that referral, whether that be federal or state, and even on the federal level, which U.S. Attorney's Office. So you have to know what that criteria is. But first and foremost amongst that criteria is they're going to want to know loss amount, and evidentiary wise, is there evidence of intent to defraud? SIUs, we don't find fraud. We find evidence of potential fraud and evidence of knowledge and intent through the work that we do. It's up to the judicial process to actually find whether it's fraud or not. But if we can create a roadmap in our referral that shows that there is evidence that this provider knew what they were doing was wrong and did it anyway and benefited from it, and it's in line with perhaps certain criminal statutes like False Claims Act, the Healthcare Fraud Act, those are things that the law enforcement is going to look for in a good referral. Is what's the loss? What's the evidence? Does it lead me to showing that this person had knowledge that they were intentionally defrauding the program or not? Those are the basics. But to get to a really good referral, you need to collaborate and communicate with the law enforcement agencies to whom you're going to be referring, because they are going to have thresholds. They're going to have priorities. The prosecutors are going to have specific areas that they're interested in, other areas that they're not going to be interested in, whether that be because they've done too many of them, they don't have the resources to deal with it. However, whatever the criteria may be, you've got to learn those things so that you're not going to use your resources to take something all that way just to have it refused because they were never interested in the first place. Mm-hmm. You want to, so effective case packaging is, you state right up front, here's the rule, here's how it was broken, here's what the benefit was, and here's what the loss is. You get that packaging up front, and then here's why it should be prosecuted. The prosecutor's job and the law enforcement's job is very difficult. For us in the OIG, we were literally making a federal case of something. So we had to have the best information possible and answer all of those questions. Bill talked about an investigative technique is to say, why isn't this fraud? Why isn't this fraud? And keep answering that. Well, it has to be. It's answering those questions in your investigation that's going to allow the OIG or the Mafuku or the local local police departments and sheriff's offices and whoever might be prosecuting these matters to be able to say, yeah, this is a good case. You've already looked at the possible defenses and you've defeated those. So all of those things go into that effective case packaging. And again, appropriate attention to restitution. As you're referring it, you want to work with law enforcement to say, here's the loss amount. What actions can we take up front to perhaps, recoup some of those monies in the meantime, so that, some of these prosecutions take years. And, during that time, is more money going out? Is the bad money still available? Because in many ways, in many instances, the money disappears, whether it's overseas or in properties that we can't track. It does go away. So working with law enforcement on a continual basis to find the best remedies of, here's a good case, you take it, what can we do administratively in the meantime, is very important.
Mhm.
Go ahead.
Matt, along those lines, statistically, restitution in criminal cases is a tiny percentage or proportion of what payers get back in a given year, money that actually comes back in the door. But I recently saw a very rare instance of a government sentencing position in a guilty plea involving several providers, a lay facility owner who was a ringleader, and an SIU investigator, ironically, who was colluding in the scheme to keep the attention away from it. But in this case, the restitution award is in the millions of dollars, and the government said the ringleader apparently has the assets to pay restitution immediately. And that's something you don't want to miss a boat when a prosecutor puts something like that in writing. So the importance of measuring a case and identifying potential assets that are there for restitution, and then making sure that you don't miss the boat on filing a victim statement with the court,
Right.
For getting the restitution.
Absolutely essential. Yep.
So once in a blue moon, that situation might arise where you can see a big restitution award actually come back to you.
Yeah, and also, on the commercial side, the government, the judicial system is going to take care of its own first. They're going to have restitution to Medicare and Medicaid first, and then if there's commercial losses and there's still money left over, then they can order that. But they look to the internal programs first.
Mm-hmm.
On civil actions, criteria, Bill just brought it up. One of them is, do they have the ability to pay? Are there assets there, or are the prosecution going to, trying to get blood from a turnip? So trying to find evidence that they do have the assets is very important. You don't have to prove or find evidence of actual intent, but there is a knowledge factor. Knowledge being that they knew or should have known that what they were submitting on that claim was false, or had reckless disregard as to whether it was false or not. They didn't care. So those are the types of things you have to look for to bring something up for civil action under the Civil False Claims Act. It's knowledge that what they were submitting was false. And knowledge has a very legalese definition that includes, should have known. So no head in the sand type of defense would really work. So you have to show that the provider knew or should have known, and that's through interviews of the provider, their billing staff, the other folks involved in the practice, to show, what were their instructions? Were they ever told that this could be a problem? Did they ignore those things? All of those things have to go into, the investigation to bring it to a successful civil action. And it can be individual or joint. You'll see in a lot of civil cases, it's severally or jointly liable for the amount. So if you're after multiple providers, or a provider is part of a larger group, the civil action can be brought against all of them, and then all of them would be jointly liable for whatever restitution and penalties were awarded by the court. And then effective insurance fraud litigation resources. Yeah, those are absolutely needed. You need to have folks in line that can, work with U.S. attorneys' offices, local AG's offices to take up those litigation efforts, whether that be parts of QUITAMs or individual suits. That you need the resources to be able to litigate those matters along with those entities.
Matt, I'm just looking at the clock. We've got about 8 minutes left.
Okay.
We want to be sure to go over on the prevention side as well.
Yep.
I would just note here under direct financial recoveries, again, history shows us through all the NHCA surveys that the lion's share of money that insurers actually get back in the door in any given year comes through this direct demand by the SIU saying, okay, Dr. Brown, you did it. We know you did it. We've got 6 inches of evidence here that proves you did it. We want the money back. And by the way, we still need to fulfill our compliance responsibilities and reporting to the insurance fraud authorities or to the medic or to the U.S. Attorney's Office, depending on the case. So those things do come into play. In compliance, we just listed for you the many people to whom might have compliance obligations, depending on the nature of your business. But let's take a quick look at prevention before we hit the time. Prepayment detection and deterrence. The holy grail in healthcare fraud for almost as long as I've been in the business, and I'm sure the same, Matt would say the same.
Yes.
How do you stop it from going out the door in the first place rather than having to chase it afterwards? But there needs to be a corporate or an enterprise emphasis on keeping that money from going out the door first. And how do you begin to achieve that? Prepayment avoidance and savings at the transaction level. Some of it requires human review. Some of it can be technology systems based. CCI edits being a good routine garden variety example of how not to pay things in the first place. New exposures. Matt mentioned transcranial exams done by ophthalmologists. Things like transcranial magnetic stimulation for depression treatment. Every time a new technology or new treatment possibility comes down the pike, you can rest assured someone is going to try to exploit that. So you have to sort of keep a barometer of the industry, the medical side of the industry, on what is coming down the pike, what's new, what might be a potential exposure next year that we've never dealt with before. What kind of red flags would we look for if someone is exploiting that particular thing? Your benefit policies, the design. One thing an investigator needs to check is at the outset of a case, does that particular policy actually allow for this? If so, then we can't run this as a fraud investigation. The policy says it was okay. So let's not waste our time. How often do you re-credential? Sometimes the policy says every 3 years. People will say, well, that's what the policy says. We actually haven't done it in 5 years now. That's something you're creating a vulnerability. They're creating a gap. Vendor contracts, PBMs especially. I saw one plan recently where the PBM contract doesn't even mention the words fraud, waste, or abuse anywhere in the contract, let alone specify who's responsible for what components of that anti-fraud oversight in the PBM relationship. Appropriate sanctions of network providers in your provider network agreements and so forth. Right now, I can't see other half a screen here because I'm seeing myself in that. There we are.
I just want to throw one thing in, Bill, in terms of the new technology and combine that with the anti-fraud provisions and contracts. One of the things we were seeing repeatedly in the UPICs was new technology being created by device manufacturers and then wholesale to providers through the sales staff, where the sales staff were giving billing advice to the providers. Bill it this way. No, it's this is how it's covered. And even though it wasn't covered, they were saying use these codes to bill it. For example, P-stim, the electronic acupuncture that they put a needle in your ear, bill it as a internal surgery into a spinal implant for $7,000. That's how it gets paid. Mm-hmm. Now, that type of issue, hugely wrong, hugely illegal, but there's no hook to those salespeople, to those manufacturers, because there's no contract between the SIU and those folks. It's the providers, but it's those manufacturers that are actually causing the false claims to be submitted.
It is, and the DME schemes aimed at Medicare Advantage and private payers in recent years, where you had companies in California billing, California, Nebraska, Florida, Georgia, all billing the same plan for the same patient for everything from chest orthotics to elbow braces, knee braces, and so forth. When you look at the letters, when providers would submit supporting records, you'd see cookie cutter letters saying, I, Dr. Jones, hereby I've examined the patient and I'm hereby prescribing the following. And then the product description would be something that only the manufacturer would know. It was clearly cut and pasted or from the manufacturer's specs and inserted there. There's no way the doctor would know the weight, the dimensions, all this of the particular knee brace that he was ostensibly prescribing for the patient in need. So yeah, there is that external vulnerability that's sort of beyond the reach contractually, but they have to keep an eye out for.
Yep.
And finally, deterrence. If you have a strong policy, do you enforce it? If people perceive that, well, it's just words on paper, there really is no consequence to what I'm doing. If I just have to pay the money back, do community service, something, then I might be inclined to keep doing it. But appropriate enforcement of your anti-fraud policies based on your referrals to law enforcement, based on your civil actions, your direct recoveries. And finally, a strong, effective compliance program. That goes without saying if you're in the government business, government money business. But internally, you need that as well, because that's another thing regulators look at, and it is a complement to the anti-fraud function. One, we're doing everything we can to pursue fraud against us effectively and against our customers' money. But two, we're also working very hard to comply with everything we need to comply with by the nature of our business. We've taken it to 1:59, but we very much appreciate you having joined us today, and we're sorry for the audio glitch at the beginning, but as we said at the outset, we hope this has been a useful, somewhat enlightening session for you that will, if nothing else, give you some very good food for thought to discuss within your own organizations and against which to measure your own organizations.
Yes, thank you all very much for listening. And as Eric said at the beginning, we hope this is the first of many such webcasts that we'll be providing.
Thank you all.
Thank you.
Hey, and thanks. Just to close out, for those of you that are interested in getting a copy of the PowerPoint, it can be made available. All you need to do is send an email to hello@advizehealth.com. That's hello, HELLO, @Advize, ADVIZEHEALTH.com. We can send that to you. The email address is here at the bottom of the screen under my beautiful face. We thank you all for taking the time to join us, and we look forward to seeing you at our next webinar. Have a great day, everybody.
Thanks, Eric. Thanks, Matt.
Thank you. Good. Well done.
Hey, likewise.